Welcome everybody to today's topic, getting to the heart of the matter, ICD-10-CM coding for cardiology. I want to introduce Christy Pollard. She's a senior consultant with more than 20 years of industry experience. She is responsible for the development of our web-based and instructor-led training materials, often conducting training in ICD-10-CM PCS, CPT, and just about any topic you could ask for. She also performs DRG and APC audits for us. She's a Colorado native, and I have to say, Christy's got a little cold today. She is finding out once you have kids, those kids tend to bring home those colds. But she's a trooper. She's going to go ahead and present for us today. So, Christy, I'm going to turn it over to you.
Okay, thank you, Kathy. My colds seem to always happen around Wednesday or Thursday of the weeks that I present webinars, so occupational hazard right now. I'll do the best I can. Today's agenda, as we go through the ICD-10-CM coding for cardiology, there are a few conditions specifically that I wanted to focus on, and some of them are ones that have had changes recently over the last couple of years. Others are things that I think are just generally kind of tricky to code and things that we have seen issues with on some of our audits. So the topics that we'll be covering today are hypertension and hypertensive conditions, pulmonary hypertension, heart failure, coronary arteriosclerosis, and acute myocardial infarction. Good times, right? I think it's good times. Heart stuff is like one of my favorites. Anybody who knows me knows that I'm all into the heart stuff. So should be a fun presentation today. Okay, starting with hypertensive diseases. And these are categories I-10 through I-16. I will say that I'm not going to spend a whole lot of time on code I-10 today, which is just unspecified hypertension. It's pretty straightforward. I don't think it's too tricky. And the joke about how ICD-10 gives us I-10 is getting kind of old, I think. It was really funny in the beginning. But moving on to some of the other hypertensive diseases and really looking into the guidelines, I think is where we need to do some focus. And for those of us who've been coding for a long time, I think it's really important to get back to the coding guidelines. As I was preparing this presentation, realized that it's been such a long time since I've read the hypertension guidelines. There are guidelines for things that I didn't recall, and always good to go back to it. So on this slide, we see sorry, trying to get my laser pointer up there, the tabular listing for the section I-10 through I-16. And this is a great reminder that we should be looking at all of the notes, not just for the code that we're assigning, but at the category level, the section level. So in this case, it's that section I-10 to I-16, which is right before code I-10. And then also at the chapter level. And I know as we code more and more, we kind of get out of that habit. And if you're using an encoder, a logic-based encoder, I know that we're not always in the book, but it's good to remember that these instructions are in the book and that the official coding goes according to the book and not the encoders. So there is a note at the beginning of the hypertension section that tells us to use additional codes for tobacco use or exposure or dependence, depending on what's going on with the patient. And this is a category or a note that we will see for a lot of the cardiac risk factors, or for those cardiovascular diseases. That's the big word I was looking for. Cardiovascular diseases where the use of tobacco is a cardiac risk factor, and it's built into the coding system here. So don't forget to add those codes if the patient does have tobacco use or tobacco exposure. The guidelines that we're going to be looking at are in category 1.C.9.A, And I'm not going to give you a presentation of guidelines because, hello, snooze fest. But I will give you a couple of guideline numbers so you can go back and refer to those later, unless you have your guidelines open right now and you're a super coder geek and you're going to like highlight as we go. And man, if you're that person, then I'm right there with you. So we're going to start with hypertension's effect on the heart and looking at hypertensive heart diseases. Hypertensive heart disease is the leading cause of hypertension-associated deaths, and it's the first thing that physicians are concerned about when they note that a patient does have high blood pressure, and they're really concerned about getting that down so that the patient doesn't experience heart disease. So what the increased blood pressure does is puts stress on the heart. And remember that the heart is a muscle. And what happens when muscles are overworked, they get bigger. It's why a lot of us go to the gym or, do our body pump or whatever it is you like to do at the gym. And typically for other muscles, getting bigger is a good thing, but for the heart, it is not. And when you put excess stress on the heart, it can lead to heart failure, ischemic heart disease, and left ventricular hypertrophy. So the hypertrophy is what happens when that heart muscle gets overworked. So hypertensive heart disease is classified to category I11. And for those of us who've been coding for a long time, as in, going back into ICD-9 and just a couple years into ICD-10, we used to have a documented relationship between hypertension and heart failure, but with the clarification of the WITH convention a couple years ago that says that if you have a condition in the index or tabular, two conditions that are linked with the word with, that you can assume a cause and effect relationship. So we now assume a cause and effect relationship because WITH is embedded right underneath hypertension in the index, and then you'll see heart failure and heart involvement are included there. Really important notes at the category level in the tabular list, though. And that is a note that tells you that this includes any condition in category I-50, those are your heart failures, as well as I-51.4 to I-51.9 due to hypertension. So if you have coded hypertension and then you have another code that's classifiable to one of these codes, then you should be using a combination I-11 code instead of coding them separately. And remember on the previous slide, I said that hypertensive or ischemic heart disease was one of the potential results of hypertension, but note that ischemic heart disease or coronary artery disease is not one of the conditions that's included. So category I-25 is not included here. And for newer coders and inexperienced coders, I think this is a more difficult concept. So it's this inclusion note here that we're really focusing on that's going to get us to this combination code. And then you have separate codes for hypertensive heart failure or hypertensive heart disease with or without heart failure. And notice that for those patients who do have heart failure, we are supposed to use an additional code to identify the type of heart failure. And we're going to talk all about heart failure later. So the next condition we'll talk about is hypertension's effect on the kidneys. And hypertension is the second leading cause of chronic kidney disease. I know you're dying to know what the first is, but I bet you already know it. It's diabetes. And this causes hypertension, the increased blood pressure, causes the blood vessels to stretch, and that causes scarring and weakening of those vessels, and then it makes it hard for the very blood-rich kidney to filter the blood effectively. So if you kind of remember back to your anatomy days where you've got these blood vessels that go into the glomeruli, which help filter the blood, when those get damaged because the blood pressure has damaged the vessels, then it interferes with the body's ability to remove waste from the body. Our codes for hypertensive chronic kidney disease are in category I-12. And similar to hypertension and heart disease, we assume a linkage between hypertension and CKD. The notes on the inclusion and exclusion notes under this category do tell us that this includes any condition in N18, which includes all of our CKD codes, and N26 due to hypertension, and arteriosclerosis, or lists out several others. You'll notice that excludes one. It excludes hypertension due to kidney disease, so that's kind of the opposite. Instead of the hypertension causing the kidney disease, it's the kidney disease that causes the hypertension. And then the excludes two note telling us that acute kidney failure is not included here. And remember, excludes two means that you can code more than one code. Excludes one, pick one. Excludes two, code two if both conditions exist. So the codes in this category are divided based off of the stage of chronic kidney disease, or at least in broad categories. I-12.0 being stage 5 CKD or end-stage renal disease, and then category I-12.9 being hypertensive chronic kidney disease, stages 1 through 4. So cardiorenal syndrome, we're kind of building here. We talked about hypertensive heart disease. We talked about hypertensive kidney disease. Now we're going to talk about cardiorenal syndrome, or hypertensive cardiovascular and cardiovascular disease with chronic kidney disease. Excuse me. I'm going to be sneaking sips of my tea throughout this to try to keep my throat going. So I-13 is our category for hypertensive heart and chronic kidney disease. And again, we have this includes term that includes note that tells us that if we have any condition in I-11 with any condition in I-12, that we are to assume or go ahead and assign a code from category I-13. Now, for those of us who've been coding for a long time, this probably doesn't seem like news. It probably seems like I'm rehashing old guidelines that we've known before, but I will tell you that these combination codes are some of the biggest findings that we've been having on audits lately. And we suspect that it may be due to computer-assisted coding logic, that the CAC, I call it CAC, that's probably not the best thing to call it, but we're assuming that the CAC is, assigning these separate conditions, and that the coders are kind of missing it on the back end. So I would say that if you are using computer-assisted coding software, be on the lookout for this. It's something that we're seeing in our audits, so I'm sure we're not the only ones. Sorry for the laser pointer there. I went a little crazy for a minute. The codes within this category are set up to identify the broad stage of CKD, either stage 1 through 4 or stage 5 or end-stage renal disease, as well as the presence of heart failure. And this grid here just kind of shows you a pictorial of how the codes fall. So code I-13.0, stage 1 through 4 in a patient who also has heart failure. Just read your code descriptions very carefully. And then you use additional codes for your CKD stage, as well as the type of heart failure if present. So underneath each of these individual codes in category I-13 will be code also notes telling you to assign additional codes for those other conditions. One of the common questions we have gotten over the years since they made this linkage between CKD and diabetes, made it automatic. The question has come up, what happens if a patient has chronic kidney disease with hypertension and diabetes? And there is a coding clinic from a fourth quarter of last year that tells us that we can assume a causal relationship between hypertension and CKD, as well as the diabetes and the CKD, because of that with convention in the index. And they actually said that, you know, the classification assumes that relationship between both the diabetes and the CKD and the hypertension and CKD, but they also said, you know, the CKD is probably related to both the hypertension and the diabetes when the patient has all three conditions. So you've got a patient who's got high blood pressure in vessels, and vessels that are weakened by diabetes that can easily deteriorate and affect the kidneys. So the example we gave here is a patient admitted with end-stage renal disease, hypertension, and type 2 diabetes. So you would assign all three. And I'll just tell you that that was how I sequenced it, but I would say sequencing depends on the circumstances of admission. And since, you know, they've got both diabetes and hypertension, if the reason they were admitted was because of the end-stage renal disease, then probably either one of those could go first. And I always hate to commit to that without seeing a record. You know, a lot of people have sent me coding questions, and my answer is usually I can't answer that without the documentation. So there's always an exception. You see our little heart here looks really tired. That's kind of how I feel when something comes up. But what happens when you have CKD due to diabetes but is not linked to the hypertension? And if they are saying that the diabetes caused the CKD and specifically say that the hypertension did not, then don't assign a code from category I-12. The example that I gave here was a stage 3 CKD due to chronic glomerulonephritis in a patient who also has hypertension. So the chronic glomerulonephritis would be assigned N03.9. It is not one of the codes that is listed under hypertensive CKD. And we're coding out the end-stage renal disease and the hypertension separately. So then we have secondary hypertension. And actually, I would say in the scenario I just gave, we might actually want to query and see if the glomerulonephritis might be causing the hypertension. I'm not sure if that's a thing specifically, but there might be situations where you want to see if there really is a linkage and talk to your physician. So secondary hypertension, category I-15, I think is a category of codes that is frequently overlooked. And specifically, this code for renovascular hypertension. And I really had to dig on this one and do some research because I've not coded a million cases of renovascular hypertension. However, this is the case where the renovascular disease, so you've got a narrowing in your renal artery, is causing hypertension. So in hypertensive CKD, we have hypertension that causes the kidney disease. This is kidney disease causing the hypertension. And in these patients, a lot of times they may be seen in a cath lab. You might see this with some of your cardiologists when they do a cardiac cath. My favorite joke of the week, you know, what is the best way to a man's heart is through his groin. That's a cardiac cath joke. But usually they go in, and I know they're doing a lot of them radially now, but the traditional way of getting the catheter up into the heart is going through the femoral artery. They go up through the aorta, they do their heart cath, and then sometimes as they're pulling that catheter back, they're going right by the renal artery, so they shoot some dye in there, and it's something that the payers have really cracked down on because it was so common there for a while. They shoot dye in there. We call them drive-bys, but we don't code them unless there's medical necessity. And it used to be we would say, you know, it needed to be hypertension as medical necessity. Well, you know, I think this is a stronger code. So if you do happen to see that and they're doing a renal angiography at the same time as a heart cath, and they say that the patient has renal artery stenosis, then you might want to check with the physician and see if this is a secondary hypertension that should be classified to code I-15.0. And again, guidelines for all of these that I've listed on each of these slides so that you can check them out. And that's going to bring us to our first polling question for today. Miss Kathy.
Thanks, Christy. Okay, I just opened the poll. So here's the question, and this is what we want to know from you. Renal vascular hypertension is classified to category I-12. Is that true or false? Christy was just talking about this on the previous slide. Renal vascular hypertension is classified to category I-12. Do you think that's a true statement or a false statement? I've got about 50% of our polling audience. Looks like we're going to have a little discussion here, Christy, but I do have a majority response. So anybody else want to weigh in on this one? I'm going to close the poll in 3, 2, 1. Christy, we've got pretty overwhelmingly at 93% is saying this is a false statement. And then 7% says it's true.
Okay, so this one is false. Remember, renovascular hypertension is the one where the renal artery disease is causing the hypertension, so it codes to the secondary hypertension category instead of category I-12, which is hypertension with chronic kidney disease. Okay, thank you, Kathy. We'll move on to our next slide. Talk about hypertensive crisis. So this was about the part in the coding guidelines when I realized that I've not been paying as close attention to the hypertension guidelines as I thought for the last couple of years. There are guidelines for controlled hypertension and uncontrolled hypertension, which, by the way, both tell us that uncontrolled and controlled hypertension both are assigned to the appropriate code from categories I-10 to I-15. I-16 is the code for hypertensive crisis and is not the same thing as uncontrolled hypertension. So the terms that we're looking for in hypertensive crisis are hypertensive urgency or hypertensive emergency. And the most severe of those two being the hypertensive emergency, where the patient has target or organ damage, as opposed to hypertensive urgency where they don't have the organ damage yet. These are add-on codes. These get coded in addition to a code from category I-10 to I-15, depending on the type of hypertension and hypertensive conditions the patient has, and then these codes go in addition. So I guess the best way for me to segue into some of our other conditions is with pulmonary hypertension. We are outside of the I-10 to I-16 categories. Pulmonary hypertension is its own entity. When we talked about hypertension in categories I-10 to I-16, that's systemic hypertension. But we're now talking about increased blood pressure within the pulmonary arteries, which is kind of a closed circuit compared to the rest of the body. You've got blood that's flowing from the heart into the lungs and then back again. So it's going out, picking up oxygen, and then coming back. So patients with pulmonary hypertension have increased blood pressure within the pulmonary circulation, and that blood pressure, high pressure, causes the heart to work harder to pump the blood and can lead to cor pulmonale. And cor pulmonale is a condition that causes the right side of the heart to fail and is usually caused by that increased pressure due to pulmonary hypertension. So the types of pulmonary hypertension, and I have at the header here says secondary pulmonary hypertension, but technically group 1 is primary. Pretty much all of our pulmonary hypertensive categories are due to another condition. They're due to something other than unknown. So group 1 is pulmonary arterial hypertension, which includes idiopathic pulmonary hypertension. The other groups are what you're going to see more common, where we've got a patient who has left heart disease that's causing pulmonary hypertension, or you've got a patient who has pulmonary hypertension due to lung disease. These are the patients who have COPD or obstructive sleep apnea. Group 4 is pulmonary hypertension due to blood clots in the lungs, so patients with pulmonary emboli. And group 5 is pulmonary hypertension due to blood and other disorders. So the codes are in category I-27, and you'll see we only have one code for primary pulmonary hypertension. It is I-27.0. And then we have all of these codes for additional. We do have one code for kyphoscoliotic heart disease. Kyphoscoliosis is a condition of the spine where you've got abnormal curvature front to back, and that can interfere with the way that the pulmonary arteries are pumping blood. All of those others, the groups that I was talking about, are classified in subcategory I-27.2. And I put in parentheses kind of what's in the inclusion notes underneath each code. I just didn't have enough room on this slide for you to be able to read it, to be able to put them underneath. But you'll notice that this code I-27.20 is our default if there's no other information. And then we've got group 1, group 2, group 3, 4, and 5. We have a separate code for cor pulmonale. And cor pulmonale is an add-on code. So if you have a patient who has pulmonary hypertension and cor pulmonale, you are going to be assigning one of these other codes as well as the I-27.81. And by the way, there is a code for acute core pulmonary. It's in category I-26, which happens to be the same category where we classify pulmonary embolism. So if you, let me go back for 1 minute. If you notice, chronic is a non-essential modifier in I-27.81. So unspecified cor pulmonale, if it's not specified as acute or chronic, is assigned to this code. You would not assign a code from category I-26 if the patient does not have a pulmonary embolism. So quick example here. I pulled this case from 4th quarter 2014 coding clinic and switched it up just a little bit to be more specific on the type of heart failure. But this was a decompensated acute on chronic right heart failure with cor pulmonale secondary to severe pulmonary hypertension. And I realized now that I forgot to add my new 5th character for that secondary pulmonary hypertension. Those were new a couple years ago. And that's going to bring us right into heart failure. And my guess is when you heard about today's presentation, you wanted to hear about heart failure because I think the codes are really confusing. And let's just talk a little bit about what is involved in each type of heart failure. Up until a few years ago, we had a lot of codes for left heart failure and one code for right heart failure. And they expanded those codes a few years ago, so we now have a lot of codes for right heart failure as well as biventricular heart failure, in addition to our heart failure codes. So if you think about the way blood is moving through the heart, we've got blood coming up in through the vena cava into the right side of the heart, goes into the right ventricle, up into the main pulmonary artery, out into the lungs where it's going to pick up oxygen, bring that back to the left side of the heart through the pulmonary veins, go out through into the left ventricle, and then goes out through the aorta to the tissues of the body. And when you think about right versus left heart failure, the symptoms are really going to be what's going to help them know which side of the heart is failing. So on the right side of the heart, if we have problems with the right ventricle, so we've got some dysfunction going on here, then what's going to happen if this side of the heart doesn't beat properly? We're going to get backup of blood in the body's tissues. And so we end up with peripheral congestion. And these are patients that you see who have really horrible peripheral edema where their legs and their feet swell up. They may have ascites, they may have some liver congestion or some congestion within the GI tract. In the left side of the heart, if we have problems with the left ventricle not pumping blood out of the heart efficiently, then it's going to back up into the lungs. So we then have patients with decreased cardiac output because that left ventricle, which is responsible for pumping blood to the rest of the body, is not pumping efficiently. And we're going to have pulmonary congestion because since it's not getting rid of that blood, it's going to back up somewhere. And the place that it is right before it gets to the left side of the heart is the lungs. So these are patients who have impaired gas exchange. They're not efficiently taking in oxygen and giving off carbon dioxide, and they also have pulmonary edema. When we talk about left heart failure, we talk about systolic and diastolic heart failure. And a lot of that is in reference to the patient's ejection fraction. And I put this slide in here to explain what an ejection fraction is so you have an understanding. This is not meant to give you coding advice. It's just I'm a big fan of the why behind the what. Why do we do what we do? We have systolic heart failure, which is heart failure with reduced ejection fraction, and diastolic heart failure, which is heart failure with preserved ejection fraction. So that begs the question, what's an ejection fraction? And really, all it is it's a measurement of the amount of blood that gets pumped out of the ventricle. Excuse me. And it's calculated by with an equation of the amount of blood pumped out of the ventricle over the total amount of blood in the ventricle. In systole, you have the ventricles contracting, so they're pushing blood out of the heart. In diastole, you have the ventricles relaxing, so that they're filling, the ventricle is filling. They can measure ejection fraction using a couple of techniques. Echocardiogram seems to be one of the most common now. They can do it during a left ventriculogram and a cardiac cath. They can do an MRI heart scan, Muga scans, CAT scans, any of those to calculate ejection fraction. Usually they're going to be looking at the left ventricle, an LVEF, left ventricular ejection fraction, because they want to make sure that that left ventricle is pumping blood efficiently. So that's all that this means. And we do see this terminology listed underneath the codes for systolic and diastolic heart failure. So the codes for left heart failure are included in subcategories I50.1 to I50.4. And those codes include your unspecified left ventricular failure, as well as systolic and diastolic heart failure. Excuse me, and a code for patients who show components of both systolic and diastolic heart failure. Your fifth characters are for the acuity, and these are a really big deal to CDI. To be able to say that the patient has systolic or diastolic heart failure is important in making sure that we have appropriate payment, but these acute and chronic change them from just a CC potentially to an MCC. So acute on chronic systolic heart failure is going to pay more than a chronic systolic heart failure. And that if you get those kinds of queries and see those kinds of queries, that's why, because there is quite a payment difference in those. And we're trying to get physicians used to documenting acuity on everything just so we can get more specific with our coding. As for other types of heart failure, these are codes that were expanded a couple of years ago, and they expanded the right heart failure codes to kind of mirror the left side. Not as far as the systolic and diastolic, because that's a left heart thing, but as far as acute or chronic or acute on chronic, we're able to report those for right heart failure now. We also have a code for biventricular heart failure, high output heart failure, end-stage heart failure, which is something that we've never been able to report before. And then, of course, as with everything else in ICD-10, we have our other and unspecified codes. Let's take a moment to look at the stages of heart failure, because this was an aha moment for me when these codes were presented to the Coordination and Maintenance Committee. It was something that I was not aware of, and it was something that was never built into the codes and not something we needed to know. But the stages of heart failure, and I just want to clarify that these are different from the New York Heart Association's clinical classifications of heart failure that are classified as Roman numeral 1, 2, 3, or 4. Those reflect the severity of symptoms and are a lot of times used in cardiac registry, but are not part of our code set. Stages A through D are part of our code set. So stage A is pre-heart failure and doesn't code to a heart failure code. This is a huge thing for us to be aware of as coders, because historically we see the word heart failure and we assign the code. But if he says it's a stage A heart failure, it actually codes as an other specified personal risk factor, code Z91.89, and not as heart failure. Stage B means that the patient has asymptomatic left ventricular dysfunction. That does code to the I-50 codes. Stage C is symptomatic. You can see that my heart is starting to look a little more alarmed at this point, and also is coding to the I-50 codes. And then stage D, and he just looks pooped out. This is end-stage failure and requires 2 codes. So you'll have a code from categories I-50.2 to I-50.4 or I-50.9, as well as your I-50.84 code to show that the patient is in end-stage heart failure. So we don't really have anything unique for stages B and C, but stages A and D are different. And that's going to bring us to our next polling question. Kathy.
Okay, the question is, which stage of heart failure isn't coded using the heart failure code? Is it stage A, B, C, or D? And I'm watching the responses trickle in. You guys are pretty quick. What do you think? Which stage of heart failure is not coded using the heart failure code? And Christy just talked about this on the previous slide when she was talking about the stages, stage A, B, C, or D. Okay, looks like we've got about 3/4 of our polling audience. Anybody else want to weigh in? I always encourage discussion if there are a group of you together and just kind of getting a consensus. I'm going to close the poll here in 3, 2, 1. Christy, we've got, again, an overwhelming majority at 96% is saying the answer is stage A, and we do have a couple people who are saying it is stage B.
I was watching the answers come in, and I had like 100% at stage A for a little bit, and I was going to say, nailed it, you know, like a whole Pinterest thing, only really nailed it, not like the Pinterest fails that we see. It is stage A. So this is the patient who has a risk factor for heart failure, but doesn't actually have the heart failure yet. So they get that Z code instead of an I-50 code. Thank you, Kathy. We are going to move on. And I just wanted to include a statement before we move on to coronary artery disease about heart failure with pleural effusion, because I've had this come up in some questions. A lot of times it's a discussion between CDI and coding on whether there really should be pleural effusion coded separately from heart failure. Remember that those patients who have left-sided heart failure are going to have backup of fluid into the lungs, and typically that gets treated with a high dose of Lasix. They call it aggressive diuresis, and that would all be included in the heart failure code and would not be a time when we would code pleural effusion separately. But there may be a time when the pleural effusion is so bad or it's unrelated to the heart failure and they need to tap the lung, do a thoracentesis, and when they are going to do something above and beyond that aggressive diuresis, then you can code the pleural effusion separately. And this was addressed in Coding Clinic, second quarter 2015. So chronic ischemic heart disease is category I-25. We think this is hilarious in Colorado. And when I say hilarious, it's code or humor, because Interstate 25 in Colorado is our central north and south corridor, and it's kind of tricky to get through, and it's blocked a lot. And blocked coronary arteries is category I-25. So I just think it's, you know, amazingly appropriate. Incidentally, the other major interstate we have going east-west through our state is I-70, and that happens to be blocked peripheral arteries in ICD-10. So, you know, you got to find the humor where you get it. Anyway, coronary artery disease, chronic ischemic heart disease, arteriosclerosis, atherosclerosis, lots of terms that describe the same basic thing, but they're all classified to category I-25. I will say, because I've had this come up before, that I know that arteriosclerosis and atherosclerosis are not clinically the same thing. Arteriosclerosis is hardening up the arteries. Atherosclerosis includes that plaque buildup, but they all code to category I-25 in ICD-10. The beginning of this code category does have that note about tobacco use and exposure, so make sure you're adding those codes if you've got that documentation. The elements to coding CAD, and it's easier to spell and say CAD than arteriosclerosis or atherosclerosis, so that's what we got. We're going to look at the type of vessel, whether it's a native coronary artery or a bypass graft, or potentially even if the patient has had a transplant, a transplanted heart, is it the native vessel or the bypass graft of that transplanted heart? And we're also going to, it's not mentioned on this slide and probably should be, that the presence of angina or absence of angina, and if they do have it, what the type is. We also have some add-on codes for the type of coronary lesion. Those are listed out here. We're going to revisit those in more detail in a couple of slides. So your CAD codes take up several pages in the code book, and I think they're confusing if you just look at it. So I tried to put this in a format that's easier to understand. So you can see that all of the codes for our atherosclerosis of the native heart are on the left side, divided by native artery and bypass graft. And with bypass graft, it gets pretty specific. What kind of a graft was it? Was it an autologous vein, autologous artery, non-autologous biological graft, or something else? And then for the transplanted heart, native artery versus bypass graft. And again, you're going to have your codes are going to be specific here to with angina and then the type of angina. Your add-on codes, these are codes that were added in ICD-9 not too long before the transition into ICD-10, but I still find that coders have a lot of questions about them. The first code that we'll talk about is I-25.82, which is a chronic total occlusion of the coronary artery, or a CTO. These lesions are really hard to cross and cross with, a guide wire and a catheter to be able to do some sort of a percutaneous coronary intervention. The picture that's shown at the top here shows the progression from a healthy artery to one that gets clogged and becomes completely occluded with the collateral circulation. So the blood can't go through, it's got to go somewhere, so it sprouts its own circulation to go around that area of blockage. Because these are hard to cross, they're hard to treat, and this is data that they wanted to be able to capture. So if you have documentation of a chronic total occlusion, that this is your code. Other codes that determine how it will be treated are for lipid-rich plaque and calcified coronary lesions. So patients with lipid-rich plaque, I-25.83, that's important to the physician because he may want to use a drug-eluting stent to treat that. And then the calcified coronary lesion means that that plaque is just really hard. And again, similar to our CTO, it's going to be hard to cross, it's going to be hard to treat, and to get the vessel to stay open. All of these codes have a statement, an inclusion note underneath it, say to code first the coronary atherosclerosis. So these get coded second. These are not primary CAD codes. And again, just your first code will describe the location. The second will, if you have any of these, will describe the type of lesion. So the example, chronic total occlusion, or CTO, of the acute marginal artery with unstable angina pectoris. We first assign our code for for the CAD of the native artery with the unstable angina, and then I-25.82 for the CTO. There is a code for angina without CAD, and just know that CAD and angina are linked in the index with the word with, which means that anytime both conditions exist, we assume a cause and effect relationship. But you may have a patient who gets diagnosed with angina pectoris without CAD, and those are assigned to category I-20, and the type of angina is your fourth character. And that could be due to a vasospasm, which is the picture that's shown here, or other conditions where there isn't a blockage in the coronary arteries. So the coronary artery disease, the next logical thing to talk about is acute myocardial infarction, or AMI. And these are the patients who have, you see our normal artery here, a nice healthy tissue, as opposed to the patient with atheromatous plaque, or CAD. And now they have this cardiac muscle death because the muscle is not receiving blood supply. Your acute myocardial infarction, just a reminder, is anything that occurs within the last 4 weeks. Healed MIs, those that are older than 4 weeks, are reported with code I-25.2, old MI. That's actually the title of that code. The description is old MI. Your types of AMI, and this is something that is new within the last couple of years as well, and has caused a lot of questions. So hopefully we can get through some of those issues today. The type of MI that we always think of as a type 1, and that's where the patient has some sort of blockage, either due to plaque rupture or thrombosis. includes STEMI and NSTEMI. Those are terms that have been really prevalent over the last probably 10 years. And again, just what we think of in the traditional sense of myocardial infarction. Type 2 has been emerging, and we finally have a code for it. This is an MI that's due to a supply and demand mismatch. So something has happened to where the heart can't keep up with the amount of blood that it needs, and they end up with an infarction. This is due to some other condition, and it has nothing to do with the coronary arteries. It can't be treated in a cath lab. They treat a type 2 MI by treating the underlying condition and returning the patient back to their normal status. Type 3 is sudden cardiac death. You probably will not be coding this. These are patients who are dead on arrival. Unless you have that documentation in the record, which a lot of times we don't, you probably won't be able to code for a type 3 MI. Type 4 MIs are due to some type of percutaneous coronary intervention. So 4A is due to percutaneous coronary intervention, or PCI, and 4B is due to an in-stent thrombosis. And then type 5 is due to a coronary artery bypass surgery. So we're really hoping we're never coding type 4s and 5s, and you probably won't see type 3 very often, but type 1 and type 2 you're going to see pretty frequently. So let's talk type 1. When we talk about initial versus subsequent, they all refer to type 1 AMI. There is no such thing in ICD-10 as a subsequent type 2 AMI. I'll say it again. When we're coding in ICD-10, there's no such thing as a subsequent type 2 AMI. So in a type 1 initial AMI, they're classified as either STEMI or NSTEMI. STEMI stands for ST elevation MI. They can see it on an EKG, and they can localize it to a specific part of the heart. And usually based off of an EKG, they can tell you which heart wall was affected. If they take the patient to the cath lab and do some coronary angiography, they can usually get that all the way down to the specific artery. So if the patient had a cardiac cath, you should be able to localize this to the artery and not be using the unspecified or the other specified wall. So if you see the anterior wall is I-21.0, but underneath that code or that subcategory, you have specific codes for left main coronary artery and left anterior descending coronary artery MI. And then you have your other specified anterior wall as well. And under inferior wall, you have right coronary. Under other sites, you have your circumflex. This is a great image of the coronary arteries. I think this is an image that I use in any training I do where we're talking about the heart and coronary arteries, and I refer to it as well. It shows you which branches come off of each of the main coronary arteries, and I think this is invaluable. The NSTEMI is a non-ST elevation MI, and NSTEMIs cannot be seen on EKG. They cannot be localized to a specific part of the heart wall or a specific vessel. So what you need to know is if the physician has documented an MI and he classified it to a site coded as a STEMI, even if he called it an NSTEMI, if it can be classified to a specific wall or vessel, then code it as a STEMI. Also, there are guidelines about what to do if you have an NSTEMI that converts to STEMI or vice versa with therapy, that you code the STEMI. So let's just say in general that STEMI trumps NSTEMI, unless it's a different event, and we're going to talk about subsequent here in a minute. So this is all in guideline 1.C.9.E. So speaking in those subsequent MIs, and again, our heart looks really tired, and he's tired because he had an MI less than 4 weeks ago, and now he's got another one. So subsequent MI occurs within 4 weeks of a previous MI. Notice at the top of my slide this says type 1. There is no such thing as a type 2 or 3 or 4 or 5 MI in ICD-10. I-22 only classifies type 1 codes or type 1 MIs. And these are classified to the specific wall, except for end-STEMI, of course. But they don't get down to the vascular level like the primary ones do. How do you sequence them? And I still see people having trouble with this. I think a lot of it is remnants from ICD-9, which I thought was confusing, and I think this is less confusing. Your sequencing depends on the circumstances of admission. I listed a couple of examples here that I'm not going to read out for you, but here's my trick. I-21 ends in a 1. That was the first MI the patient had. I-22 is the second MI that the patient had. Sequence appropriately. If the patient had an MI 3 weeks ago and they came in today, your I-22 code goes first, followed by your I-21. If they came in on Tuesday and had an MI and they're still in-house and today is Thursday and they had another MI, then you code your I-21 first and I-22 second. So I-21, 1 is the first MI the patient had. I-22, 2 is the second one they had. Type 2 MIs, there's only one code. Makes it super simple. The code is I-21.A1. And again, this is an AMI caused by a supply and demand mismatch. And this doesn't matter if he's unfortunate enough to have more than one of these within a 4-week period, it's I-21.A1. You don't code it more than once because we don't repeat ICD-10-CM codes. But this one I think is fairly straightforward. Other MI, I-21.A9 includes type 3, 4, and 5 MIs. And so, they're so rare, or hopefully should be so rare, that they've been all grouped into one category or one code, and we don't have to code those out separately. There is a guideline about this that provides sequencing instruction if you need that. So there have been some questions about subsequent MIs of a different type. And remember, I said it more than once, type 1 MIs are the only ones that get classified as initial and subsequent. So if you have a subsequent MI of a different type, then you're going to have 2 codes from category I-21. And there was a new addition to the coding guidelines for this year that reiterates that you do not assign a code from category I-22 if there are MIs of different types, and the codes from category I-22 should only be assigned if both the initial and subsequent MIs are type 1 or unspecified. And that brings us to our very last polling question. Kathy.
Okay, the question reads, a patient presented with type 2 AMI 3 weeks after STEMI. What is the type 2 MI code? Is it I-21.3 STEMI, I-21.A1 type 2 AMI, or I-22.9 subsequent AMI? I'm going to read it one more time. A patient presented with type 2 AMI 3 weeks after STEMI. What is the type 2 MI code? Is it I-21.3 STEMI, I-21.A1 type 2 AMI, or I-22.9 subsequent AMI? And responses came in a little slower than the other ones. So if anybody else wants to weigh in, or I'm going to close it so that Christy can take a couple minutes to discuss this. I'm going to close it in 3, 2, 1. So Christy, we've got answers kind of all over the board. We've got the majority at 76% is saying it is a I-21.A1 type 2 AMI. followed by 19% is saying it's I-22.9 subsequent AMI, and then we have a minority at 5% I-21.3 STEMI.
Okay. So the question, I think, sounds a little confusing at first. The patient presented with a type 2 AMI 3 weeks after the STEMI, but the question is, what is the type 2 MI code? And whether it be first or second, it doesn't matter. It's always B, I-21.A1. Remember that your type 2 MI codes are not ever coded to category I-22, and a type 2 AMI is not a STEMI because a STEMI is a type 1. And that is my presentation for today. I have listed out several of the references because I didn't go to medical school to do this presentation, which for some of you is pretty obvious. But here are some of the references that I used in building today's presentation. And I know I'm right at time, slightly over. So Kathy, do you want to explain how we're going to handle questions?
Absolutely. So I'm going to leave the chat window up for a couple seconds or a couple minutes. So if you have any questions, because no questions came in during the presentation, but feel free and type it in or go ahead and email Christy directly. But what we are doing now is we are posting the FAQ. So any questions that come in between now and tomorrow afternoon, we will make a video out of it and post it on our YouTube channel. So feel free, let us know if you have any questions or comments about today's presentation. And we want to thank you for your time and attention, and we want to thank Christy for a wonderful presentation. So be sure you take a couple minutes, fill out the survey, let us know how we did today for you, and let us know about any additional topics you would like us to add to our webinar series. So again, thank you very much for a great afternoon, and go and have a wonderful rest of your week. Thanks. Bye-bye.